next session, ICU and cardiac anesthesia. So I will present for the first lecture, the first speaker, Professor Elise Ghaib. He has an expertise in intensive care medicine and in perioperative care of patients hospitalized for cardiac, thoracic, or vascular surgery and ECMO. He has several research on ECMO and ARDS. He's former head of the Mechanical Circulatory and Respiratory Support Unit at Amiens Hospital, France. He's also former deputy head of anesthesiology and intensive care department of Avicenne Hospital, Assistance Publique des Hôpitaux de Paris, France. He's now physician in the anesthesiology and intensive care department of Ambroise Paré Clinique at Neuilly-sur-Seine, France. And he will talk about right heart failure during cardiac anesthesia. Welcome, Professor Ghaib. The floor is yours.
Hello, everybody. I would like to thank the committee organization and the president of LSA. And I will be pleasure to have this presentation with you. Right heart failure is a significant cause of mortality and morbidity after cardiac surgery, necessitating early recognition and prompt treatment. If not, it will be difficult to go with to deal with the treatment. After cardiotomy, we have 0.01% of incidence of this right heart failure. And after orthotopic heart transplantation, it goes up to 18%. After left ventricular assist device, we will have 5 to 30% of right heart failure. So it's a very important issue to have the diagnosis and the treatment. Up to 22 to 90% likelihood in hospital mortality are due to right ventricular failure after cardiac surgery. It's a significant mortality, and including prolonged mechanical ventilation, intensive care unit stay, renal or hepatic failure, and increased need for inotropic and mechanical circulatory support. So we need to have a definition. Its prognostic importance, right ventricular remain under investigated, and without a universally accepted definition in the perioperative setting, it's difficult to have the real definition. The provision of a standardized perioperative definition for right ventricular failure is based on practical and objective criteria will help to improve quality of care through early detection of these pathology. So it will give better outcome. It's typically presenting intraoperatively as difficult to be separated from cardiopulmonary bypass, characterized by either concurrent use of more than one vasopressor or more one inotropic drugs, or inhaled pulmonary vasodilator, requiring more than one cardiopulmonary bypass weaning attempt for presumed right ventricular failure, or mechanical support device to facilitate with intra-aortic balloon or right ventricular advice. And it will go to anatomical visualization of impaired or absent right ventricular wall motion by the surgeon or by another type of investigation as echocardiography, more than 20% reduction of every fact, and we will go back to this definition. And it will occur in postoperative period with hemodynamic criteria on arrival to ICU, with higher right pressure as central venous pressure more than 15, or lower cardiac index output less than 1.8, and the absence of elevated left arterial pressure, as we know the pressure capillary occlusion more than 18 millimeter of mercury, or tamponade or other tachycardia of pneumothorax, and high resistance. It's the definition we need to have the right diagnosis, and all these points will go to low cardiac output that lead to a multi-organ dysfunction. There are three component in the right ventricular. Anatomy right ventricle is a little bit complex with the inlet of there are three regions: the inlet region, the inflow region, the trabeculated apical myocardium, and the infundibulum of the right ventricle. It do anatomical little bit complex in the right ventricle. The ventricle are not these ventricles are not composed of the single muscle layer, but rather of multiple layers that form a 3D network of fibers. The right ventricle wall is mainly composed of superficial and deep muscle layers. The fibers of the superficial layers are arranged more or less circumferentially in a direction that is parallel to the atrioventricular groove. That's why the fiber turn obliquely toward the cardiac apex on the sternocostal aspect and continue in the superficial myofiber. And you have a twist in the contraction, and that gave two chamber in the right ventricle while the contraction of this ventricle, and that makes the definition a little bit difficult. So, and the pathophysiology of the right ventricle failure will be a little bit difficult to assess. When we we're going up to the physiology of the right ventricular, we have the primary role of the right ventricle is to pump venous return from the right atrium into the pulmonary circulation, allowing blood oxygenation by the lung. The pulmonary vascular is normally a low impedance circuit. It's an important point. Such the right ventricle is optimized for high volume capacitance and low afterload state. So it's an important point in the treatment of the right ventricular failure. Additionally, the right ventricular is a thin-walled structure with its peristaltic contraction, as we say before, due to the anatomical situation and anatomical structure. With its peristaltic contraction, it's derived from its free wall longitudinal fiber and the interventricular septum. Several mechanisms contribute to right ventricle ejection. The most important is being the billow-like inward movement of free wall. And other important mechanisms include the contraction of the longitudinal fibers, shortening of the long axis, drawing the tricuspid annulus towards the apex, and the traction of the free right ventricle wall at its point of attachment to the left ventricle as a result of left ventricle contraction. That's why when in contrast to the left ventricle, twisting and rotational movement do not contribute significantly to right ventricle contraction. Furthermore, the contraction of the right ventricle is also sequential, and they're starting with the trabeculated myocardium and ending with the contraction of the infundibulum. That's why it's a little bit complicated to have the contraction of the right ventricle. The better understanding of the complex relationship between right ventricular contractility, preload and afterload, many investigators have studied this pressure-volume relationship of the right ventricular. One of their major findings was the right ventricle follow time varying during the contraction cycle of the heart. So it's a elastin model in which ventricular elastin is described by the relationship between systolic pressure and volume ejected. So its elastin may also be approximated by linear relationship. And we can have these point of the right ventricular maximal elastin is considered to be the most reliable index of right ventricular contractility. The right ventricular elastin is lower than that in the left ventricular. This arrangement implies that the right ventricle is far sensitive to increase in afterload. When we put more volume in the right ventricle, the stroke volume will decrease when we have more pressure. It's not the same curve that in the left ventricle. It's not the same reaction when we have volume in the right ventricle, but we have to assess a small volume. And when we are putting small volume in the right ventricle, we can have an increase in the preload, and we have the positive inotropic effect. It's an effect that we have when we do loading with a small volume. We can have inotropic effect, but we can go up to an overloading, and we have to be to do with small loading the right ventricle failure, because we can have a positive effect as an inotropic effect. They said it's the unwrap effect due to the sympathetic stimulation, and with the remodeling of right ventricle, we can have a positive effect on the volume and the stroke volume in this curve. But we can go to a failure, a right heart failure with decreasing, very big decreasing of the stroke volume of the right ventricle if we put so many loading in this case. Let us see the definition. It's an inability often. The right ventricle failure is an inability of the right ventricle to provide adequate blood flow through the pulmonary circulation at normal right arterial pressure. We will discuss the common etiology of the right ventricle in the setting of cardiac surgery, and then the treatment will be more easy. First of all, it's the higher pressure overload. It could be due to secondary to elevated pulmonary vascular resistance in the context of hypertension, pulmonary hypertension, as well as in left ventricular failure, anatomic or functional right ventricular outflow obstruction, mitral valve disease, protamine reaction, lung reperfusion injury, or pulmonary embolism, or obstruction of the right ventricular tract. So we have this first point, and we do know that every time we have an overloading of the right ventricular, we have a dilatation of the right ventricular shifts the interventricular septum, as you know, as you look in this figure, and then changing the left ventricle geometry. The acute right ventricular distension also may lead to an increase in pericardial constraint. This change may contribute to low cardiac output states by decreasing left ventricular distensibility, preload, and ventricular elastance. We have a very small left ventricular volume ejection when we are a compressed left ventricular volume. We have a volume overload. It's an excessive transfusion. It's iatrogenic causes by the right ventricle overload. It will be excessive administration of fluid, as well as in the context of congenital heart defects, or for example, a natural septal defect with the left-right chant, tetralogy of fallow or pulmonary regurgitation. We can have severe tricuspid regurgitation, may also cause inadequate forward flow and right ventricular distension. This is the second cause of it, or etiology of right ventricular defect failure. A decrease in pulmonary artery pressure in patients with pulmonary hypertension may be a sign of low cardiac output and severe right ventricular failure. The pressure, the pulmonary vascular resistance goes up, it decreases, and indicates pulmonary vascular resistance. And when we have a decrease, a continuous increase in pulmonary vascular resistance, we have a decrease at some point of the curve, we have a decrease of the cardiac output going, and if we go back to our diagram, we have the ischemia, or the intrinsic right ventricular failure, that will be most commonly attributed to poor myocardial preservation with exclusive retrograde cardioplasty used in the further exacerbated by inflammation, prolonged cardiopulmonary bypass duration, or pre-existing right ventricular dysfunction. The right ventricular ischemia from coronary embolism or plaque rupture and right coronary artery with graft occlusion are another important contribution factor. We have to search these etiology to do the better treatment later on. Additionally, large preoperative right ventricular infarct have been identified as a major cause of perioperative mortality, as a dissection taking the ostia of the right ventricular coronary artery, it will be a cause of preoperative right ventricular infarctus. Another cause, another etiology will be, we have just see this point with pre-existing cardiomyopathy, the arrhythmogenic right ventricular dysplasia, acute rejection of opotherapy, heart transplantation, orthotopic heart transplantation, or cardiopulmonary bypass inflammation. This leads to more mortality, and geometric disturbance can be another etiology with acute it's critical in the setting of mechanical circulatory support, like LVADs acutely unload the left ventricle, causing a leftward interventricular septum shift and thereby reducing interventricular septum contribution to the right ventricle contraction. That's a pure anatomical cause of the right ventricular failure. This results in right ventricular dilatation and failure to maintain adequate output to match LVAD flows, ultimately leading to device section events. And then we have low cardiac output and eventual right ventricular burnout. We can have one point, we have other miscellaneous etiology as the cardiac tamponade, pericardial constriction, or mechanical ventilation caused due with hypovolemia or tricuspid stenosis. This point will be checked, but after all the etiology, we have to do the diagnosis, and the diagnosis will be assessed with the gold standard techniques used in perioperative period. As first of all, the visual assessment of the surgeon. It's a very important and easy diagnosis technique. Then we have the right ventricular catheterization, if it's possible and if we know how to do it. And then the transesophageal echography that could help to the diagnosis of right ventricular failure. Just some point that the American Society of Echocardiography recommends using at least one quantitative echocardiographic measure to assess the right ventricular when dysfunction is suspected. With this view of cardiac section by transechocardiography in the upper esophageal section, mid-esophageal section, and lower esophageal, then in transgastric section. So I will not go in the detail of this section, but it's just to resume the different section we have that gave us a good view on the right ventricular, and we will see some slide later about that. In this standardized measure, in the echocardiographic measure, we have include right ventricular size, septal morphology, and position and surrogate of right ventricular ejection fraction. This some point must be searched during cardiac surgery when we have the right ventricular heart failure as a diagnosis that we are searching for. And the right ventricular size is the best measured by the basal diameter on the mid-esophageal four-chamber view, like this view. And more than 42 millimeter indicates dilatation. There is some formula and some reference ranges with the different sizes of the right ventricular. It will be right ventricular diameter at the tricuspid annulus, or at the mid-chamber, or the longitudinal diameter of the right ventricular. It's one kind of measure that we can have. There's many kind and sometimes very complicated. I will not go in every possibility in the esophageal echocardiography view. At the mid-esophageal right ventricular inflow and outflow view at 45 degrees, we can see the ventricular measurement can be obtained during systole, and main pulmonary artery measurement is obtained during diastole, and we can have the right ventricular outflow tract and the measurement of the right ventricular outflow tract can diagnose a compression or an occlusion of in the right ventricular outflow. It's a very good. It gave us a very important view on the right atrium, on the tricuspid valve, and in the tract of the right ventricle. Let's go to another view, an important other view with which is the measurement of the fractional area change and tricuspid plane systolic that you know that the taps. This is an important 2 points that we have to measure when we are looking for right ventricular failure. Another one we talk about before is the right ventricular outflow, and this is an example of an obstruction of the right ventricular outflow, and it could lead to a diagnosis of right ventricular failure. Some new point that we have and we can assess in a cardiac surgery patient, it's the strain imaging. It's not very new in cardiology, cardiography, but in perioperative theater, it's a little bit new, and not every we need an expertise in these sequences. But we can go to this to a significant reduction of the right ventricular global longitudinal strain from 25 to 6, as you see in this strain of the wall of the right ventricular free wall. And we have, when we are on after cardiac pulmonary bypass, we have an increase in the contraction of the right ventricular wall. There's many other techniques, recent techniques and automated techniques to go to the speckle tracking of the left ventricular. It's the same speckle tracking of the left ventricular that is applied on the right ventricular, and we can have some idea about how the right ventricular is working, and if there is a failure or a very big failure of the right ventricular. The right heart catheterization, the waveform is obtained using a pulmonary artery catheter, and that goes up to the pulmonary artery and to the capillary, in pulmonary artery capillary.
Professor
These are
Zghaib,
the curve we
Professor
have when
Zghaib,
we put.
sorry to interrupt you a little bit.
When we assess these.
Sorry to
This
interrupt
right
you,
heart
Professor.
catheterization. Yes.
Sorry to interrupt you. We don't have too much time. We are already
I will go to
5 minutes.
some treatment. I will go to some treatment and we'll leave.
Thank you.
We are not going. There are some biomarkers, but they are not for you under clinical investigation. The most biomarkers will be the liver function test or serum creatinine or glomerular filtration. It's a classical test. We have to improve right ventricular failure by optimization myocardial oxygen, by putting 100% FiO2 optimal ventilation parameter, and avoiding tachycardia or arrhythmia. We have to the correction of arrhythmia and atrioventricular conduction. We have to go to manage preload right ventricular in the right ventricular failure to be with central venous pressure around 8 to 12 per millimeter per mercure. Fluid challenge might prove deleterious in the presence of high filling pressure, and it goes to the worsening cardiac output. We can do with position of the patient. Is position with it's here the head of the patient, and here we have the legs, and patient is in a position that we have a negative central venous pressure. We have to decrease the preload of the right heart in this condition. We can go to ultrafiltration per cardiopulmonary bypass, and we have to these all techniques can reduce the right ventricular afterload by using the by adjusting the ventilator without PEP, without high volume setting, by doing pulmonary vasodilators, by assessing sildenafil or phosphodiesterase 5 inhibitors, by prostacyclin derivatives, but it's not a usual use, all of this kind. We have the very quicker use, it's NO. Increasing of right ventricular contractility will be with norepinephrine or epinephrine. Dobutamine is not very recommended in this situation because it causes arrhythmia and systemic vasodilation. Milrinone could be used because it will decrease right ventricular contractility and cause pulmonary vasodilation. It has less chronotropic effect than dobutamine, but bolus doses may cause systemic hypotension. So we can put milrinone, but not with the bolus. Levosimendan, it's not very clear how can we use it. We can when we don't have any other idea, but it's not easy because of vasodilatation and hypertension. Of course, if all of this point doesn't work, we can go up to mechanical support by using intra-aortic balloon or veno-arterial ECMO, peripheral or central veno-arterial ECMO, by shunting all the right-sided heart, the right side heart, by cannulation the right atrium and aorta, or just the right atrium and pulmonary artery when it's the specific right ventricular infarction. There is some slide with a review with some diagram how to assess still ECMO assessing, and I would like to thank you and apologize for the delay in this presentation.
Thank you. Thank you, Professor Zghaib, for this comprehensive and excellent lecture. For the sake of time, we will leave the question to the end.
And now we will be with Dr. Abdou Khouri. He's going to present he's going to talk about the manual ventilation and cardiac arrest. I have the pleasure to introduce you Dr. Abdou Khouri, who is a professor of emergency medicine, Department of Emergency Medicine and Critical Care at Besançon University. He's the medical officer DOPS of Fire Department, a consultant physician for disaster medicine and terrorism, and he is instructor for nuclear, radiological, and biochemical risks and terrorism. He's the chair research team in mechanical ventilation. He's the chair medical simulation center at the University of Franche-Comté. He's the instructor for disaster medicine at the SAMU de Paris. And he's also the instructor of medical response to major incident MRMI courses. He has many diplomas, and he has an MS and PhD degree in European Masters in Disaster Medicine, EMDM, along with other, of course, diplomas. He's board certified in emergency medicine in France, and he's the president of the European Society for Emergency Medicine, ESEM. And he will be with us to talk about the manual ventilation and cardiac arrest. Dr. Khouri, the floor is yours.
Thank you, Dr. Jaber, for this nice introduction. Good morning, everyone in Beirut, and it's a real honor and pleasure for me to be here with you and to be invited to this conference. It's really something very nice, and would have loved to be with you at the same time in Beirut, but unfortunately, I'm in Berlin for the European Emergency Medicine Conference. In the next few minutes, I'll speak about manual ventilation in cardiac arrest. I'm coming from Besançon, eastern part of France. This is my city and my hospital. And I have some few competing interests, mainly with the industry, and I'm a holder of few patents for medical devices, and I work with Archeon in developing all these patents. As you know, it takes a system to save lives, and the ERC, European Resuscitation Council, have put the strength a lot on how to establish a system, a complete system in order to save lives, starting by awareness for cardiac arrest, even training kids in schools, in building cardiac arrest centers, and also in the dispatch assisted CPR. And when we go a bit deep in these guidelines and we try to see about the advanced life support, we see that the strength was put once again this year or last year on the high quality chest compressions, and also how to treat the reversible causes of cardiac arrest. This is the things that we know, but also that we should give artificial ventilation when it's possible and when we are trained for that, and of course deliver each breath over approximately 1 second, provide an adequate volume while minimizing the risk of gastric inflation and the leakages at the same time, at a rate of around 8 to 10 minutes, and of course avoid hyperventilation. And when we go on that in the guidelines and we try to see all these recommendations, unfortunately the debate is always about how to proceed to advanced airway technique, and the debate is whether should I intubate or not. And this is really an internal debate how to go for an advanced airway support. When we go to these guidelines and we see on what they base the guidelines and recommendations, we see that unfortunately they base the recommendations on 4 studies: 3 randomized control studies, I'll go through them, and 1 observational retrospective study from in-hospital. Let's go to the first one, led by Dr. Patricia Jaber from Paris. She's a Lebanese, and she's really very well known in research and cardiac arrest. And she compared the bag valve mask ventilation versus the intratracheal intubation over 2,000 patients, and they failed really to show the superiority of bag valve mask versus intubation. A second study on paramedics in the United States comparing supraglottic devices versus tracheal intubation. Paramedics, 10,000 patients. And again, they didn't show the difference between when you intubate or when you put a supraglottic device. The same when you put a laryngeal tube, when you compare it to endotracheal intubation, you have also always in EMS, more than 3,000 patients. And you have also the same thing. There's no difference in survival, whether you intubate or you put a laryngeal tube. And this is the retrospective study in the hospital, observational one. And they will even prove that when you intubate the patient, you really decrease survival. So, of course, we can question ourselves on the capacity and on the quality and on the training of those people that maintain, that ensure the airways in cardiac arrest. So again, this is a problem, and that we have to really deal with that kind of training. But however, as you see in all these studies, the question was how to ensure intubation, how to go to an advanced airway solution. Exactly the problem is not to intubate or not, is the ventilation of the question, and they don't talk about how to ensure good quality ventilation. We've done a study a few years ago in our department. 140 persons came to ventilate a mannequin, either intubated or with bag valve mask, and afterward it was crossover. The ones that start with intubation have ventilated with a bag mask valve, and the ones that start with bag valve mask ventilated with intubation. And when you see the metrics, you see that all of them are more or less on the way of hyperventilation. The rate was more than 10 per minute, average 23. And when they go to the tidal volume, we are more than what's recommended, the 6 milliliter kilo. And above all this, when we ventilate with the bag valve, to 20% of the volume is reflected. It's really something very big. And of course, it's important to ventilate. And lots of studies now are showing more and more that it's really important to ventilate. And this is one of the major studies that done by Chang, although it was a retrospective study on more than 500 patients. They just grouped these patients between the patients that were well ventilated and the patients that were poorly ventilated. When you see at the right side of this column, the patients that were well ventilated was only 25% of the global patients. And when we look at these figures, we see that the survival were more than double in the patients that were well. So it's really essential to ventilate the patient. The problem is how to ventilate. And we really, in our department, in our research group, have really work on the question. When we ventilation, either a back valve has with intubation, what are the performance keys to see correctly or not? And what will correlated with all the literature all over the world, the performance is really weak. And in the review article from the same group that Mary Chang, they really show that we really need to ventilate. It's important to ventilate in order to have a better survival, and that we should develop some kind of strategies and devices to guide the personnel for an optimal clinical performance in manual ventilation. So what about calling them ventilation feedback devices? Yes, it's kind of a feedback device, ventilation feedback device. And actually, when you search the literature, there is two devices on the market, more or less. You have the INT'L that were tested on pulmonary patients, and you see the graphs here. When you have a feedback, it's green. When you don't have a feedback, it's in blue. When you go on the, when you have a feedback, it's in blue. When you don't have a feedback, it's in green. When you look at the tidal volume, for example, and the frequencies, when you use a feedback device that will tell you that you are in the range of rate and you are in the range of tidal volume, you are really in the ranges. When you don't use a feedback, you ventilate from 10 to 25, and you have a volumes, the disparate volumes from 200 up to 600. And in every category and every kind of patient, ARDS patient, cardiac arrest patient, head trauma patient, in every category, you're hyperventilating and you're not ventilating correctly whenever we don't have. And unfortunately, this kind of device were only connected directly to the test lung. So there's no leakages, and they are not simulating really a bad valve mask. And also, they measure any tidal volume. They only measure rated volume that you press on the bag, you are hitting, and of course, no leakages. There's a new device that went on the last year, as well, a known company in cardiac arrest, radars, and everything. So Zoll have this new device. They put a new filter, and this device to ventilate 10 per minute beeps when it's need to ventilate, and when rate your volume, insuflated the correct volume or not. And then when you compare, when they go for EMT, when they go with the one that ventilated with ventilated improvement when you use the ventilation feedback device, or up to a 97% ventilation target, or up to in the time. The two indicators, volume and target, we are more or less in the target rate. So it's interesting to have kind of devices. Fortunately, once again, the tidal volume of the patient. 2 years ago, we were one of the first in the world, if not to introduce this term of ventilation feedback device. And we introduced a device in order to guide the rescuer by visual feedback on the quality of their ventilation that they are providing to the patient. And it enables them to have a high quality ventilation in all circumstances, regardless of the level of the experience of the user. So it goes well to an anesthesiologist, of an emergency physician, to a nurse, to a paramedic, to a fire department ambulance driver, for everyone that knows more or less of training in ventilation, but even if she's not very skilled, she's not very skilled, then this is how it looks like. The device that connects to the ambu bag. You can either connect the mask or connect it to endotracheal tube. And this is actually what happens when you ventilate without any kind of feedback device. This is a test study on a mannequin, ASL 5000, one of the reference models for simulation of ventilation. When you ventilate without any kind of feedback, this is what happens. These are your in rows. They are orange. You have your sequence of ventilation. In yellow, you have your pressure, and these are the volumes that you have. And you see that over 1 minute or more than 10 per minute as recommended, and your ventilation volumes are really disparate. Your pressures are completely. When you use the feedback, your ventilation is your volume up and your pressure is the same. So it's really ventilation feedback view. It looks like in the real devices. for training, one for the patient. Do not give the same feedback both of them. This one is much more for training to the professional, and over the time we connected to see the progression of your over the used on the bed. You see the device. I'm sorry, I had this.
Sorry, Dr. Khouri. Sorry for interrupting. I would like to tell you that we have only 5 minutes remaining.
I didn't hear. I'm sorry.
Sorry, Dr. Khouri, for interrupting. We're lagging behind. We're only having 5 minutes to end this lecture.
I'm okay. I'm fine. Yeah. So I don't have the video. I will not play it. So just talk time, and then it tells you today. The bug tells you if you are in adequate volume, insufficient, or more or hyperventilating you're in the target, and it gives you also a indication on your leakages and on your tidal volume. Whenever we do the of professionals, when the mask or with the ET tube, you see the device out of the range in terms of volume, where you with the device you are, and also here when you're intubated, it's the same thing. When you have the device, you are in range. These are the crosses. Where you are not in range, these conclude. Still in endless debate on how to secure. Able.
So sorry, we'll be finishing this session and this lecture, and now we're moving to the last lecture in this session.
Okay, I will welcome to Dr. Luna Shaban. She's anesthesiologist and intensivist at University Hospital Cleveland Medical Center. Dr. Luna has graduated from University Saint Joseph de Beirut, where she did 2 years of residency in anesthesia at Hôtel Dieu de France. And she did also anesthesia and perioperative medicine at University Hospital Cleveland Medical Center. Dr. Luna also has a fellowship in critical care at University Hospital Cleveland Medical Center. And she will talk about code shock team mechanical circulatory support. The floor is yours, Dr. Shaban.
I will not delay this too much. I will just go ahead and jump into it. So today I'm going to talk about the code shock team, or really focus on mechanical circulatory support. I have no financial interest or affiliation concerning this presentation. Those are the few things that we're going to discuss. We're going to quickly go through the epidemiology of cardiogenic shock, which is the main reason why we use MCS or mechanical circulatory support, define cardiogenic shock, the management of it. We'll talk briefly about what we call a shock team or multidisciplinary team that usually takes care of those patients, and we'll conclude with some future perspectives. So cardiogenic shock is currently a common cause of mortality. And according to the Critical Care Cardiology Trials Metric Registry, it's still about 15% of all admissions to the CICU, acute MI being about 30% of these admissions, the remaining being non-ischemic without acute MI or other causes. And in-hospital mortality seems to still be pretty high, around 30 to 50%. But advances in reperfusion therapy, catheterization, rapid stenting of those patients, as well as rapid implementation and escalation towards MCS seems to be associated with improvements in survival. And so this is a table that just resume a few of the factors that can influence the escalation to MCS and the actual activation of it, and that may affect how effective it is on patients. And really, the thing that I would like to talk about here is the delayed timing. So most of the time, we call for escalation towards MCS pretty late, and which will lead to further morbid mortality. And according to Tarani et al., every 1 hour delay in escalation to MCS was associated with about 10% increased risk of death. So the cardiogenic shock team was created as a multidisciplinary team that will be able to be rapidly activated in order to escalate those patients towards mechanical circulatory support whenever we think that vasoactive medication alone are not adequate to keep them to improve their cardiogenic shock. And it really started back in '67, where Edward Frank described the first shock team that was only composed of 2 physicians and a nurse that would go at bedside and assess the patients in cardiogenic shock. Obviously, they didn't have all the MCS different mechanical circulatory devices that we have nowadays. And then in 1990 in New York City was when the first shock team was created, and it's where it was associated with improvement in survival from 25% up to 66% in patients post cardiotomy. A few studies here that just showed that early implementation of a shock team was associated with better survival, like this Innova shock registry showed an improvement in mortality from 47% up to 60 and 80% in 2017 and 2018. Same thing, a study in Utah that showed a 30-day mortality improvement whenever a shock team was implemented pretty quickly on. So what is MCS used for? It's used to treat cardiogenic shock. And what is actually cardiogenic shock? It's an ineffective cardiac output that is caused by a primary cardiac disorder that will result in both clinical and biochemical manifestation of inadequate tissue perfusion, leading ultimately to multi-system organ failure. There are many definitions there to see when we can define that a patient is actually in shock. Most of them will define it whenever we have a systolic blood pressure less than 90 that is using any vasoactive medication, and any signs on lab or on clinical exam of hypoperfusion. The main causes, mostly it's ACS, and it's the first thing that we like to rule out. So it's 81% of the patients that are presenting with cardiogenic shock have an acute coronary syndrome going on. 30% is chronic failure, and the rest is anything like stress-induced cardiomyopathy, advanced valvular disease, or even postpartum. The pathophysiology, I will go through it pretty quickly. The primary insult is just a reduction in the myocardial contractility that will lead to diminished cardiac output, hypotension, a systemic vasoconstriction that initially is beneficial because will improve coronary and peripheral perfusion, but will quickly contribute to an increase in cardiac afterload, which will overburden the myocardium, lead to further cardiac ischemia, and lead to the secretion of a lot of pathological vasodilatory stimulants like nitric oxide, interleukins, and TNF-alpha that will ultimately lead to hypotension. The RV itself is less adaptive than the LV to any increase in afterload, and that's why any LV failure could lead to an RV failure pretty quickly as well. So we typically follow those patients with troponins, BNP, lactate levels that are what shows perfusion mostly. They get a chest X-ray just to rule out any other cause of this hypotension or hypoperfusion or shock state, an EKG to define if they're an ACS, and definitely an echocardiography to be able to define what the etiology is behind this cardiogenic shock, whether it's ischemia, a valvular disease, or if it's an MI-related mechanical complication. Other things that we can have is a PA catheter that will allow us to help to measure the patient's SVO2, will allow us to titrate our vasoactive medication, show us response to therapy, give us a continuous cardiac output. However, with all the data that it gives, a PA catheter has not been associated with improved mortality in those patients. SVO2 or mixed venous O2 can also be followed up and trended throughout the treatment of cardiogenic shock to be able to see whether the measures that we're implementing are working or not. So this is how we're typically following those patients. They're on tele, they have an invasive art line, a central line, because they're mostly on medication. We're following their urine output. They mostly have a PA catheter, and we follow up with their lactates and their SVO2 just to be able to titrate our vasoactive medication or de-escalate our mechanical circulatory support. Really quickly about the medical management, it's obviously inotrope and vasopressors that are on in 90% of patients that are on cardiogenic shock before we go ahead and escalate towards an MCS. And those drugs are beneficial initially, but again, will increase myocardial oxygen consumption, increase afterload, and therefore be more harmful at long term. Norepi is what we use for low blood pressure. Vasopressin whenever we're concerned for RV failure because it doesn't have any effect on the pulmonary vasculature and therefore will not increase RV afterload. Inotropes are usually given alongside with norepi, and milrinone is usually our inodilator of choice. That is especially in context of RV failure, but the problem is that it may worsen MAP because it causes systemic vasodilation. And so this is briefly a table that shows the effects of each vasoactive medication that we use. Interventional management is definitely also important because the shock trial also showed that early revascularization in patients presenting with an MI-related cardiogenic shock was associated at 6 months with improved mortality, not at 30 days, but definitely at 6 months. So now let's actually talk about the mechanical circulatory support and when we escalate to it. So as we said, inotrope and vasopressors are great until the point where they're going to start increasing the afterload and cause decreased myocardial and increase myocardial oxygen demand. And this is where MCS actually plays an important role. They can be classified by either temporary or durable devices. And really what we're going to touch base on today are the temporary devices. They're usually inserted either percutaneously or surgically and used as a bridge to recovery, a bridge to transplant, or a bridge to decision. We'll talk about intra-aortic balloon pumps, impellas, and VA ECMO. Durable devices are usually surgically implemented and are used either as a bridge to recovery, a bridge to transplant, or a destination therapy. This is mainly LVADs, and that will be a different talk. So intra-aortic balloon pump, it's a pretty simple device. It is usually inserted percutaneously through the femoral artery and sits right in the descending aorta distal to the left subclavian. Usually inflates during diastole to be able to perfuse the coronaries since they're mostly perfused during diastole, and deflates in systole. And with that, it decreases myocardial oxygen consumption, increases coronary artery perfusion, and decreases afterload. But it really only increases modestly the cardiac output from anywhere from 0.5 to 0.8 liters per minute. And according to the SHOCK 2 trial, intra-aortic balloon SHOCK 2 trial, there was no benefit in mortality at 30 days, 6 or 12 months with the use of intra-aortic balloon pump because it plays no role in myocardium salvage. And nowadays, we really use balloon pump whenever we're trying to wean a patient off bypass and they just need this little bit more cardiac output, or if it's the patient that's presenting to the cath lab with main left disease or triple vessel disease, and we think we just need to put a device by the time we're able to stabilize them and get them into surgery. This is some of the contraindications. Any severe aortic regurgitation, aortic dissection, or LVOT obstruction are the main contraindications since it will actually be aggravated by the presence of a balloon pump. Impellas are a little bit of an upgrade in comparison to a balloon pump because they allow to give more cardiac output. So depending on the size of the impella, they can give anywhere from 2.5 to 5 liters of cardiac output. Usually small impellas are 2.5 and 3 are inserted percutaneously, whereas the Impella 5.0, which is the biggest one, needs a surgical approach with an axillary cut down. It's usually via the axillary artery that they go through. So once the Impella is in place, it will be related or hooked up to this little console that we see here in this picture. And this will allow us to modify the amount of output that we want the Impella to give, depending on what P level we choose. P9 being the highest support that the Impella can give, P1 being the lowest support. And this is also how we're able to wean an Impella down. This little console also will be able to tell us if there's any malposition of the Impella, if the Impella is being clotted, if there's any suction event whenever the LV is empty or we have a decrease in the preload. So the inlet of the Impella usually sits in the LV, and then this is the motor of it, and it will suck the blood out of the LV and pump it through the outlet into the ascending aorta for the rest of the organisms. And in contrast to the intra-aortic balloon pump, the Impella acts independent of the heart function and rhythm. And as the pump flow rate increases, it progressively unloads the LV. Some of the contraindications are moderate to severe aortic valve disease, mechanical aortic valve, VSD, LV thrombus, and severe peripheral arterial disease. And now we come to the VA ECMO. It looks pretty complex in this picture, but really for me, it's the most simplest device, and I like to think about it as a mini bypass. So what VA ECMO does is it's going to drain venous blood, will pass it through a pump into an oxygenator to oxygenate the blood and return it to the heart via an artery. And it's either going to be a peripheral cannulation, usually it's femoral artery, femoral vein, or it will be a central cannulation, which is typically done in the OR via the RA and aorta. And the ECMO has been used in about 13,000 patients, and its rate of survivable to discharge is 39% when used in cardiac support. Some of the indication are any persistent refractory cardiogenic shock, inadequate tissue perfusion, malignant refractory cardiac arrhythmia, severe pulmonary hypertension, cardiac arrest, ECPR, as a bridge to transplant or an LVAD, in end-stage pulmonary hypertension, myocarditis, cardiogenic shock, or if we're unable to wean them off, bypass. Some of the contraindication are whenever we think that the cardiac function will not recover, if there's any signs of hemorrhage or contraindication for systemic anticoagulation, because those patients will need to be anticoagulated, if there's any aortic dissection, AV incompetence, prolonged CPR, lack of vascular access, advanced aged, if they have any condition incompatible with recovery, such as a devastating neuroinjury, advanced liver disease, or if their life expectancy is less than a year. This is the ARREST trial. It was the first randomized controlled trial that showed that patient that presented with VFib arrest outside of the hospital and where we obtained DROSC, if they were quickly placed on ECMO prior to revascularization, it was shown that there was an improvement in mortality in those patients. So this is when we're talking about ECPR. Peripheral VA ECMO also has complications because it will increase the LV afterload, leading to inadequate unloading of the LV, which is why they're usually combined with either an Impella or an aortic balloon pump that we call LV vent. So in order for the blood not to be sitting in the LV, we use an Impella or an intra-aortic balloon pump to vent this LV and to be able to offload it. And Russo et al. Showed that VA ECMO with intra-aortic balloon pump for LV unloading was actually associated with a lower mortality. Advantages of VA ECMO is that it's low cost in comparison to other MCS. It provides full circulatory support, even in resuscitation situations, full oxygenation, and really is the only device that will provide full support of both the RV and the LV. So this is a picture to show there are definitely some devices out there for RV support, like an Impella RP, the Tandem Heart RA PA, but we focused more on the LV in this talk. Intra-aortic balloon pump really doesn't give a lot of cardiac output, whereas Impella do. And VA ECMO, you can go up to 7 liters of cardiac output, and it provides both LV and RV support. The shock team, just a very brief word on it, was a multidisciplinary team that is usually consistent of an interventional cardiologist, acute heart failure physician specialist, a cardiac surgeon, and a critical care physician that is usually the team quarterback. This is the team that typically takes the decision of escalating a patient towards MCS or not, and to see if the patient would actually benefit from it or if there is a survival opportunity in this patient. So what about the complications associated with MCS? Because yes, it can improve cardiac output. Yes, it may be very helpful in cardiogenic shock, but it doesn't come without any complications. And the more you upgrade in those MCS, the more complications are going to emerge. So really common complications are anything like limb ischemia, like CVA, having vascular injuries. Bleeding is pretty big, especially in Impella and VA ECMO, because those patients are going to be on anticoagulation, and then infection and sepsis. Most of those patients are already also in kidney failure because of their cardiogenic shock and the hypoperfusion of the kidneys. Most of them are on renal replacement therapy, and whenever they are on that, the mortality is increased and survival to hospital discharge will be decreased. This is a table just to brief out the complications. So again, the more you upgrade from an balloon pump to an Impella to a VA ECMO, the more complications are going to be severe, especially when anticoagulation and hemolysis with Impella and VA ECMO. Finally, it's very important also whenever we're thinking of having a patient on MCS to involve all palliative care colleagues, because they usually reduce physical and emotional distress that those patients are on. Remember, they will be hooked up to a machine by the time we are able to figure out what the next plan would be. And in a lot of hospitals, palliative care is actually part of this multidisciplinary inpatient team to be able, or shock team to be able to take the decision concerning the treatment of the patient. So this slide is just to resume. Whenever we have a patient with cardiogenic shock, resuscitation will start with vasopressors and inotropy, obviously mechanical ventilation, revascularization when it's a possibility, and reperfusion, whether it's surgically or percutaneously. And then when all of this is not really working is where we're thinking about temporary mechanical circulatory support, whether it's an Impella, an ECMO, or an actual balloon pump that will either lead to recovery or will lead to a decision or to a durable VAD that could be the destination therapy or as a bridge to transplant. Those are my references, and I'm happy to take any questions. Thank you.
Thank you, Dr. Shaban, for this comprehensive and practical lecture. We will move now to the question. Is there any question in the audience? I will start my question to Professor Zogheb. I will ask you, in the era of the transesophageal echocardiography, is there any still an indication to put a Swan-Ganz catheter for monitoring of a right ventricle failure? Professor Zogheb?
Yes, sir.
You are hearing me? Okay. I'm asking if in the era of the transesophageal echocardiography, during a right ventricle failure, is still an indication to put a Swan-Ganz catheter to diagnose the right ventricle failure and to monitor?
I think during in the operating room we can have the echocardiography and we can do it. It's a continuous monitoring. it needs we have to know what you are searching about, whether there is some gastric and some volume of the right ventricle. When it's a real right ventricular failure, it's very easy to see when we have interventricular septum shift and a huge volume of the right ventricle. It's easy to assess for anesthesiologists during whenever we are not specialists and echocardiographics cardiologists. So it's easy to monitor with echocardiography. Swan-Ganz catheter, I prefer and have I put so many Swan-Ganz catheters. It's better for ICU monitoring because it's a long-term monitoring, and it's less invasive than a long-term trans-echocardiography, because the evaluation of the right heart with transthoracic echocardiography is not so easy in the perioperative period, because the probe is difficult to access to everywhere we are going to search the right heart. We can have some indirect problem, but like the inferior vena cava diameters or some other, but it's a little bit difficult. So at 4 o'clock, everybody is not allowed to do 4 a.m. In the morning, and everybody is not allowed to do echocardiography, and it's monitoring with the pressure, invasive pressure, and arterial pulmonary pressure or left ventricular pressure. It's better for everyone and we can do it at every time of the day.
Okay, thank you.
Dr. Khouri, I didn't have the chance to thank you for this concise and comprehensive lecture. And I have a question. These studies that you presented took into consideration when speaking about the superiority of the bag mask ventilation over intubation, or no superiority at all. Did they take into consideration that in crisis times or in emergency times, we need more hands? The ET tube can be, needs no human hands. And did they take into consideration that we have more monitoring with the ET tube, like the capnometers, the flow meters, avoiding barotraumas in such patients, avoiding aspiration? You know that all emergency patients come not MPO. So did they took into consideration these parameters?
Yeah, thank you for the question, and I'm sorry for the technical issue I had at the end of our presentation. Yeah, it's an excellent question, and we all know that intubating the patient is a gold standard technique, and it provides it maintains the patency of the airways, and we don't have leakages, and we don't have gastric regurg and everything. Yeah, you're completely right. The problem here is not how to advance for airways. The problem is how to ventilate afterwards. Okay, you've put your ET tube or you ventilate it with your mask, but how are you ensuring adequate ventilation? EtCO2 alone is not an indicator, because EtCO2 also in cardiac arrest is tributary from the hemodynamics of the patient also. So also it's a bit complicated to just rely on the EtCO2. And that's why we need the ventilation feedback devices to give you the tempo, to tell you at this time you have to ventilate, and this is what you are insufflating, and this is what you are having as a tidal volume. And that's why you, if you don't choose this kind of device, and that's why we are not really able to ventilate our patient. In all the studies we see, the performance range between 0% up to maximum 30%, mean that at least 2 out of 3 patients are not ventilated. And you saw in the study of Chang, 25% of these patients were adequately ventilated, not more. So we really need to find something different, and to put really monitoring and VFDs to be able to ventilate our patients. And regardless of our expertise and regardless of our diploma, whether you are an anesthesiologist or an emergency physician or a fire department, you have the same performance more or less, and we showed that in the study we published.
We still have 5 minutes for the question. Yes, doctor. Yes, Dr. Shaban, can we ask you about the role or the indication of the Swan-Ganz catheter in managing your patient in diagnosing left ventricle failure, and do you still use Swan-Ganz?
So yeah, definitely. I mean, it's true that it has not been associated with an improvement in mortality, but I would second Dr. Zghaib in what he said. Having a PA catheter is pretty helpful in the ICU, not only to be able to diagnose any RV or LV failure, but it's also helpful whenever we're trying to wean down those patients off their mechanical circulatory support. So if we're weaning down an ECMO, for example, it's nice to see what the PA pressures, what the CVP is doing, what the right ventricle filling pressures are actually doing. If they're increasing, then the patient is not ready to be weaned off ECMO. It's the same way also whenever we're trying to wean down an impella from the highest supports to the lowest support, and whenever we're even trying to wean out vasoactive medication. So we use it pretty commonly in our ICUs as well.
Thank you, Dr. Shaban. Also a question for you. You talked about timing, delay timing for putting mechanical support. What is this timing, this precious timing before the mechanical support to be put?
It's really hard to say because it's based on a case-by-case situation. But usually when we're called for a patient that has already devastating ischemia or devastating disease that is not operable on, or if they are actually on a very big amount of vasoactive medication, like on high epi or norepi, or even dobutamine doses are very acidotic, this is where the mortality will actually increase with MCS. It's better to actually implement this whenever the patient is still with a relatively normal pH, not a lactate in the 20s or 17s, and not on very high vasoactive medication support.
Thank you. Any other question? I will move again to Professor Zghaib. What do you think about the treatment for the right ventricle failure? Do you think that nitric oxide as inhaler associated with inotropes are really good enough to treat a right ventricle failure?
It's I was a little quick on these slides, but I didn't find so many new treatment that we can use more efficient than nitric oxide and the inotropics. But you have to deal with the fluid volume of the right ventricular. First of all, you have to put small volumes, but because we can have an increase in cardiac output of the right ventricle. But when we have more than some volume, and this is why we need the measure of the right pressure in the right ventricle and the arterial pulmonary pressure. When we have a little bit more than some volume, we go with the 100 milliliter loading the right ventricle, 100 by 100 milliliter. And then we have to go to the nitric oxide, to the inotropics treatment, and to discharge, going up to the ECMO to discharge the right ventricular heart failure. It's a nice indication to go quickly when we talk about timing, not more than 45 or 60 minutes with the cardiopulmonary bypass assist when we cannot wean during cardiac surgery.
I have a question for you, Professor Zghaib. What's your opinion on morphine as a vasodilator in patients with right V and increased pulmonary hypertension? And this is a debate.
Morphine? Excuse me, it's about morphine?
Yes, it's about morphine.
Yes.
And there's also, I think there's a study also about the Dormicum trial that is ongoing.
there is some indication and some characteristic of the morphine with vasodilatation of artery pulmonary, but till now I think it's we are still using the old but gold nitric oxide and inotropic till now. I'm sorry, we don't have we have levosimendan as a preventive treatment. It doesn't have any success in mortality, in decreasing mortality. When we use it in cardiac surgery and when we use it preventively, we have a problem with the doses and with the bodies that we have that we put in our patient. With levosimendan, we don't know which doses will decrease mortality after cardiac surgery when we use it before induction of the anesthesia. So it's very difficult to put the right timing and the right doses for this new treatment in these indications.
Thank you so much. Do you have any questions? Okay, our dear speakers, thank you so much. We came to the conclusion of this session. Thank you.